Okay, I'm gonna try this again. I recorded the whole thing and it said it was good, and for some reason it only recorded the first 3 minutes. So you see that on YouTube, I'm putting the corrected one up. This is chapter 44, which covers peripheral nervous system. Chapter 43 and 45 are on the central nervous system. So on this first half, we're going to cover Guillain-Barré and myasthenia gravis because they're so closely related, and then we'll pick up on the rest on the next lecture. I put information here on several different slides going over the parasympathetic and central nervous system. Notice your peripheral nervous system is your cranial nerves and your spinal nerves, and organization which affects what, because we will talk plenty on the slides about the sympathetic and parasympathetic and what they affect here. This is a really, really good slide here on the sympathetic and parasympathetic. Parasympathetic, rest and digest, feed and breed. The sympathetic, fight or flight. Remember, the parasympathetic is cholinergic, so we start talking about cholinergics, cholinesterase. Those are feed and breed, rest and digest, where you have saliva, slow heart rate, constricted airway, stimulate stomach activity, release of glucose, so you think of your glucose being elevated, intestinal activities, contracting the bladder, promoting the hormones and then the opposite for anticholinesterases. Okay, so your Guillain-Barré syndrome it affects the nerves in the brain and the spinal cord. You see where it causes a demyelinization. They don't know exactly what causes it. It is an immune response. It's uncommon, affects males slightly more than females, peaks after the age of 55, but some places say it affects from the age of 30 to 60 or 40 to 60. It is a progressive, acute type crisis. It can be triggered by a bacteria or a viral response, sometimes may be closely related to immunizations, or you've had an illness and then get an immunization and this results. This is a good picture on the risk factors and symmetrical paralysis. There is no specific test to diagnose it. They can do a spinal tap that may or may not, if they get it at the right time, show some extra protein or albumin, but it's not going to show anything else. It's really to rule out other causes. Because there is no specific test to diagnose it, there are certain criteria that have to be present, which is progressive weakness of 2 or more limbs due to neuropathy, areflexia. They have no reflexes. The course is less than 4 weeks, and they can exclude all other possible causes such as toxin, botulism, diphtheria, a spinal cord injury. The symptoms are in initial muscle weakness with ascending 3 stages. The acute or initial period, 1 to 4 weeks, which begins with the onset of the first symptoms and ends when there's no further deterioration. So this is ascending. It starts at the feet, it works its way up. You don't know how far up it's going to go. It may go all the way up and require them to be on a ventilator, or it may not. So that's the first stage, is while it's progressing. The plateau period is when it no longer progresses but is not regressing yet. It can be from several days to 2 weeks. Recovery phase is gradually, it descends the opposite direction from the ascension. It can be a matter of 4 to 6 months or as long as 2 years, and some people don't get all of their, recover all of the neurological deficits. Occasionally that happens. Due to the demyelinization, which was in this picture here, the nerve impulses can't get through and they have exposed nerve fibers. So it is very painful, more so at night. So that is a key of a nursing intervention, is for this management of the pain, which often require opioids and possibly like Neurontin something for that neuropathic pain. The assessment is the paresthesia, numbness, and pain. Chart 44-1 gives you your key features, your motor, sensory, cranial nerve. Now understand, it does affect specific cranial nerves. On your second part of this lecture, the second thing, I do give you pictures. It's on this whole PowerPoint, but on the second lecture, more things on actually the cranial nerves, because you need to review and understand your cranial nerves, your involvement. There's facial weakness, dysphagia, diplopia, difficulty speaking. I told you about the pain. They can have paresthesia with that numbness, tingling. They can also have hyperesthesia, where they're hypersensitive to any touch. Another key factor with diagnosing is that there is an absence of fever. EMG studies are not diagnostic, but they will show that there is demyelinization that has taken place. They just have to rule out all the other possibilities. Management. Apheresis or plasmapheresis is one option. This is a good picture in explaining what plasmapheresis or apheresis is. It removes the circulating antibodies that are assumed to cause the disease. The plasma is selectively separated from the whole blood, and then the blood cells are returned to the patient without the plasma. The reason for you want to look over the possible complications, the reason why the hypocalcemia is because of the citrate. Citrate is used in all these blood products to prevent clotting of the blood cells. So unfortunately, citrate is a calcium binder. So when they are taking this through, returning the blood to the patient without the plasma, that calcium can be pulled out. So you have to be on a calcium supplement and be monitoring the calcium levels. Also, because it affects clotting factors, you are monitoring your clotting factors, and you're looking for depletion of coagulopathy. That's why you have that. And with this, there's the potential for itching urticaria, so you may be giving diphenhydramine for that effect. Fluid shift or depletion, whether getting too much fluid or getting too little fluid, the rating that from this, so you're monitoring for fluid overload or fluid deficit. There's always potential for anaphylaxis. You treat this as any blood product transfusion. Precautions, vital signs every 15 minutes in the first hour, and as you're finishing over the last hour after you finish. Watching the site. I forgot this slide goes over some of the possible complications. Hypotension if you're pulling off too much fluid, septicemia, introducing pneumonia with abnormal clotting. I covered hypocalcemia, and here's some contraindications. The hemostatic disorder, unstable cardiovascular state, active infection, and pregnancy are contraindications. They also may use IVIG, intravenous immunoglobulin. It's readily available. It's a little more expensive than plasmapheresis. It may have less complications. There is risk with it. It has to be given slowly, watching for anaphylactic reaction. Anytime with Guillain-Barré, because the airway can be affected, you are monitoring the ABGs, their tidal volumes, keeping the airway clear, because the facial muscles are affected, checking for swallowing, airway, breathing, circulation. They're immobile, so preventive for DVT, deep vein thrombosis, doing the prophylaxis with low molecular weight heparin, SCDs, range of motion, PT, OT, ST, all the therapies involved, definitely dietitian involved for the nutritional support, managing their pain, which I mentioned they can be hypersensitive. Older patients, they can use tricyclics for managing this pain, but older patients can have serious anticholinergic effects with the triptylines. The triptylines are like amitriptyline. So that anticholinergic effect, if you look at your parasympathetic side, if you're going against the cholinergic or parasympathetic side, an anticholinergic is you can't see, can't eat, can't pee. So you're looking for urinary retention, constipation, distress, nausea, vomiting because the gut's not working, double vision, blurry vision, that sort of thing for the anticholinergic effect. Communication can be a problem because of the facial paralysis that is temporary. Lots of emotional support, family support, getting through this crisis of this. Okay, we're going to move on to myasthenia gravis, which is so closely related in a lot of ways, is why I grouped these two together. Myasthenia gravis begins on page 917. It is an autoimmune disorder that affects the acetylcholine receptors, which I mistakenly started talking about it with the MS on the last lecture. I apologize for that. This is the one where the acetylcholine receptors that are necessary for the nerve impulse to transfer over, the antibodies attack that acetylcholine receptor so the nerve impulses can't pass over. And so they do not have, it results in a lack of muscle contraction. Sometimes the people with myasthenia gravis also end up with a hyperplasia, overgrowth of the thymus, which is interesting because the thymus is not active in our life. It's active in infancy through probably early childhood, and then it just kind of shrivels up, and I don't know why it's there. But with myasthenia gravis, often they get hyperplasia or enlargement of the thymus gland, may or may not be due to a cancer. It's not always enlarged, but can be enlarged. Majority, 2/3 of people start with ocular symptoms right here. Ptosis, which this is a good picture showing you the lid drop, but they're unable, if you notice, they're unable to close that eye. So when we get to nursing care, that's something to keep in mind. Diplopia, which is a double vision, if you think of how difficult that is. Nausea, vertigo feelings, and wrist falls. The facial muscles that are affected, so you think of unable to chew, swallow their saliva, close their eyes, maintain safely their airway, provide enough nutrition for themselves. These are just key things to think of when you're thinking of nursing management. Your chart breaks down the different classes as it's progressive. There are 5 classes ranging from class 1, which just affects that eye, all the way to class 5, which affects everything and often will end up needing to be on a ventilator. Unlike Guillain-Barré, which is a temporary case that hits acutely rapidly over 2 to 4 weeks, myasthenia gravis, the great majority of the time, is insidious, where it's progressive over a very long period of time. Occasionally, there may be an acute onset because due to great stressors or pregnancy, hormonal shifts in the body, but majority are very insidious onset. It is progressive from the proximal muscle weakness. So instead of going from the feet up the body, this starts in the proximities and around the facial muscles. They have poor posture, ocular palsy, ptosis of double vision, they can have respiratory compromise, loss of bowel and bladder control, fatigue, muscle achiness, paresthesia, decreased sense of smell and taste. This next picture shows you the synapses here. This is the normal neuromuscular function. You have calcium and sodium channels, the acetylcholine, the receptors here allowing this transaction to take place. On page 918, your text talks about this here, this Lambert-Eaton. Lambert-Eaton is a form of myasthenia gravis with small cell lung carcinoma, and it also affects the muscles of the trunk, pelvis, and the shoulder. Diagnosed with EMG, muscular studies, just like myasthenia gravis is. The treatment is to remove the cancer and administer drugs to release the acetylcholine They may have additional therapies like plasmapheresis and IVIG or immunosuppressive therapies that you do with myasthenia gravis. In this tumor, they have calcium channels on the tumor surface. The calcium channels on the tumor surface act as antigens to the immune system, and the autoantibodies are produced against these calcium channels. It causes a cross-reactive immune response at the synapses and prevents that synapse from taking place. So the goal is to remove that tumor and treat the effective myasthenia gravis symptoms. This is with myasthenia gravis. If you notice, most of it is in that facial area with the difficulty talking, positioning head, change in voice, facial paralysis, difficulty chewing and swallowing, weakness of eye muscles. They can progress into different stages, different phases with or levels. With the breathing difficulty, fatigue is common in all of it. They can have difficulty climbing stairs and lifting objects. That's where some of the classes have, where it says it affects the axles. That's where this comes in. And if you again think of the nursing care, think of all these things, of all the nursing factors involved with not just your airway, breathing, circulation, which is pertinent here, but also your ADLs, your emotional state, and everything. So we're going to move into management. Many things are done with immunosuppression, plasmapheresis, respiratory support, nutritional support, their eye protection. I'll recap on those in a little bit. On here, you notice these are cholinergic agonists. So they work directly on the muscarinic, nicotinic, which are the receptor sites in the parasympathetic or cholinergic side of this autonomic nervous system. Because of the acetylcholine, which is part of your parasympathetic nervous system, so these drugs work to stimulate that parasympathetic cholinergic aspects, or to here indirect acting. So the pilocarpine, nicotine, neostigmine, some of these drugs, they are listed on page 920, where it talks about the two groups of drugs, anticholinesterase, the other cholinesterase inhibitor drugs, which is the first line of treatment in myasthenia gravis, anti-myasthenics, anticholinesterase drugs, because you want to reverse what's going on with the body. So this slide here goes into different options. Where are they? I don't see them on here. Pyridostigmine, which is an anticholinesterase drug. Also, you can do the plasmapheresis just like you do with the Guillain-Barré, IVIG, just like Guillain-Barré, you're pulling out those antibodies, or you're trying to give them what they need. Prednisone is often used, cyclosporin, azathioprine. Now remember this pyridostigmine, because that's given later when we talk about a surgery. All of these will affect the liver. You are monitoring anticholinesterase drugs. You are monitoring their liver enzymes, especially your CBC, your platelet clotting times, your platelets, and your white blood count. Remember your platelets with the effect of the citrate. With myasthenia gravis, there are many drugs that you have to use with caution or totally avoid. Your streptomycin, which these are your aminoglycosides, ciprofloxacin, levofloxacin. If it has if it has floxacin in it, those are your quinolones. Any of these mycin drugs, along with these aminoglycin, the mycins, quinine, magnesium, propranolol, your beta blockers. If you think about beta blockers, they block the beta cells on your acting on your sympathetic nervous system, which is the opposite of parasympathetic, so it can aggravate that parasympathetic response, is why you would avoid those. Okay, so there's a myasthenia crisis and cholinergic crisis. Distinguish between the two. Page 920 says the potential adverse effects of cholinesterase inhibitors is cholinergic crisis. So if you're blocking that cholinergic side, if you're inhibiting, if you're inhibiting it, you can go two ways. One, if your drug levels are too high, you can go into a cholinergic crisis. So you think of exacerbating that parasympathetic side. So the slow heart rate, the weak and fasciculating muscle, constricted pupils, warm and flushed, increased secretions, aggravated weakness, all the opposite of the fight or flight. Or if you miss a dose, and not just miss a dose, they can miss a dose by an hour. It has to be on a set time. I think it's like within 30 to 45 minutes of not having the dose, within exactly 24 hours, they can go into a myasthenic crisis. So either they're underdosed or they're late on a dose, missed a dose, they go into a myasthenic crisis, which if you think of like your fight or flight, the opposite of the parasympathetic or cholinergic response. So you have your tachycardia, except that your muscles are weak because you're not synapsing. Pupils can be normal or dilated. Skin is faint or cold because the blood is going, everything is shunting to the core. Your niastigmine test is improved. This theostigmine, this is your test called your text refers to as your tensilon. It's here on page 919, a cholinesterase inhibitor edrophonium test that may be performed using an anticholinesterase. This is for clarification of diagnosis or distinguishing between whether they're in a myasthenia crisis or cholinergic crisis, because sometimes the symptoms can almost overlap. So sometimes they will use this to distinguish them. Know that this test, they have alerted in your text, can cause cardiac dysrhythmias and cardiac arrest. Although that is very rare to occur, have atropine sulfate readily available. Myasthenia gravis is one of the most treatable neurological disorders. If everything is followed through appropriately, it can be managed. This myasthenia crisis is a medical emergency. It sometimes can be caused by an infection. There can be a mixed crisis between the two. So teaching is essential. Cholinesterase crisis, myasthenia crisis, both are critical and life-threatening. With the cholinergic crisis, because the bradycardia, there's atropine. So in your teaching, and especially family support for going home, they need to know CPR, they need to know how to use suctioning equipment, O2, bag mask, having one available for if a crisis should occur. Factors that exacerbate myasthenia gravis are infection, stress, surgery, physical exercise, use of sedatives, enemies, anesthesia, strong cathartics, overheating, crowds, overeating, erratic changes in sleep, emotional stress. Obviously, they can't go to nursing school because I think everyone's experiencing those. Some more things with myasthenia gravis: plasmapheresis, which is the other that you would use with Guillain-Barré. Please be familiar with plasmapheresis, potential complications, what you're looking for, the calcium, the clotting, the fluid overload, the hypovolemic, hypervolemic problems, and thymectomy. I mentioned the thymus gland might be enlarged, might be a tumor. It can either do an open sternum or go in with a scope like this. If they do an open sternum, they will come out with a chest tube. Be familiar with what you'd be looking for with chest tubes. The thymectomy may not reverse or stop the progression of a myasthenia gravis. They try to do it within the first 2 years of onset of the symptoms, and they try to do this before a young woman because it's more common in females actually goes through a pregnancy because the hormone shifts. But if they're young and they catch it early, they will try to do this. Plasmapheresis versus IVIG. Neither is more effective than the other. It does not help to do both of them. One may be more expensive. Both have some complications related to it. So, okay. Then before I finish up, some key things. Taking the medication 30 to 45 minutes before eating. Being aware of drug interactions. Writing down the medications for the patient. For teaching, understanding the self-management, having good support around them, all the stressors that need to be avoided, the strict importance of taking the medications at set times, nutritional support, communication issues. I mentioned the diplopia, the ptosis, where the lid is drooped, but they need eye protection, so you'll be using in the hospital. They will be hospitalized when they initially try any of this testing, or if they're do a thymectomy, or if they're in a crisis, they will be in intensive care. You must provide eye care with ointments, gels, covering up the eye. The text suggests covering one eye for 3 hours, transferring the other eye. This is teaching they need to do at home to prevent corneal abrasions and pain. Further damage to the eye. Rest is critical because repetitive movement can precipitate a crisis. They will need long-term physical therapy, emotional therapy, speech therapy, every type of therapy. Make sure you can distinguish on table 44.1 the different crises and some things that look very much alike, what would be done to distinguish between the two. They have another alert because respiratory compromise often occurs in myasthenia patients. Encourage family members to learn resuscitation. I think I mentioned that. It is episodic, it has flares, it has relapses, it is progressive in nature. There is no cure for it. Just try to slow down and give them more periods of remission, but there is no cure for this disease. And that is the end of part 1 of chapter 44. Continue to complete chapter 44 on the next lecture, and I just put a little humor in here, hoping to help decrease some of your stress level, and I'll talk to you with the next lecture.